Hello, my name's Dr. Allen. I'm a GP and I'm the Clinical Director for Primary Care in Sheffield, and I've got somebody with me today who's got some very important things to share about the future of general practice.
So my name's Nat Jones. I'm an occupational therapist. I'm on a clinical doctoral fellow with the National Institute for Health Research, and I'm currently working 1 day a week in Primary Care Sheffield.
So tell us what you've been doing and what you've been learning.
So Primary Care Sheffield asked me to do a review of ARRS roles. So that's the additional roles reimbursement scheme where GP practices can draw down funding to employ a number of new roles within primary care. And there are 13 of those roles. And I was asked to go out to the networks and understand what the barriers were to those roles, but also what the benefits were and whether there are any gaps that we might need to explore and improvements that we could make.
Great, yeah. So I understand ARRS roles to be a really crucial part of the workforce. They've come in, but it's a big change, and we need a lot of effort to put into thinking about how do we make sure that we get the best out of them, and that's what you've been doing. So tell us, what do you think are some of the key things that you've learned?
Sure, I think one of the most important findings is around team-based working. So the shift from individuals working in silos within networks or practices to working as a primary care team, and understanding what mechanisms need to be in place to support that shift into team-based working, and looking at areas where they've really matured their thinking around that, and they're starting to coordinate their efforts as a primary care team in a network, working together, supporting each other. It's been fascinating to see how that's evolving.
Okay, have you got an example of that working well?
Yeah, so in one of the networks in Sheffield, they've developed a personalised care team where they have an occupational therapist leading that team, and there are a whole range of ARRS roles working together, centralising referrals so that the team can look at those referrals and make sure that they signpost to the right ARRS roles. It's a good way to utilise your resources if you centralise referrals, making sure that the right people with the right skills are seeing the right patients. But also it's looking at maybe a number of ARRS roles working together with a patient so that they can meet all of their needs in a holistic way. So organising the workload, structuring the team so that they have regular team meetings, MDTs, but also providing that peer support and supervision structure that's needed to ensure that their health and well-being as an employee is good.
Because I know that retention has been one of the big challenges. So what are some of the ways what are some of the changes that people could make perhaps to try and improve retention?
Yeah, so I interviewed a number of people that had left after around 18 months of being in post, and it was interesting to explore what are the factors that either keep you in post or facilitate you leaving. And one of the biggest things was creating a sense of belonging and connection to either practices or the network, and making you feel like you're part of a team, that people understand your role, that you have a voice within that team, that you are valued for your contribution, and that you are cared for, and there is compassion within the workplace. And building that sense of connection seemed to be the most important thing that people said, I want to feel like I belong somewhere.
And how can that happen? So what changes could people make in their practices and their networks?
So I think, the example that I gave earlier around building a primary care team so that the ARRS roles work together. They have a regular touch point as a team, so to team building exercises, but also that the work is organised and shared out across the team, and opportunities to understand each other's roles and to know where, for example, I fit within that organisation.
Yeah, and I know you've talked about how the roles have often come in during the pandemic, and for teams to work well together, it's so important to just to even get to know each other and have that kind of rubbing up against each other day to day, just learning about each other's lives, and that kind of happens face to face when you're in the same building, doesn't it?
Yeah, absolutely. And it doesn't have to be the GP practice. It could be a community centre. It could be a church. Anywhere in your community where you can create a space for that team to come together is really valuable that time, because everybody's managing heavy caseloads, complex patients, very often people in trauma. So, having support with that and knowing that you can see your peer and get some support is really important. Everybody's working agile, and their space in practices is at premium, so it's not always possible to get everybody in the building at the same time. So finding places where you can create a little space, even just once a week, is highly valued, and people are feeling like that's making a difference to their working life.
So creating a sense of belonging and building trust can often feel a bit fluffy, but actually that's where often you build the relationships to make difficult decisions, but also that's kind of where you kind of build the connections to be able to give a sense of belonging and be able to enjoy your role, and that then can lead to retention as well.
Yeah, absolutely.
So what are the other kind of really important takeaways?
So when I talked to the people within ARRS roles, one of the things they talked about was, I want to be able to influence, I want to lead, I want to feel like I have a voice in how things develop strategically. And very often people felt a bit pigeonholed into roles because maybe they've been traditionally working in that way, or maybe it's an idea that's been created and they've come into it, and having an opportunity to influence how that role develops, but also think really differently about what you could do at a population health level. So, having opportunities where people in ARRS roles can have a voice within the practice, within the network, where they can, talk about their work, have it recognised, but also maybe explore doing things in different ways so that you could get the most out of those roles.
Yeah, because one of the challenges, hasn't it, with this whole scheme is around organisational development, but actually one of the answers to who can lead the change is the actual roles themselves, isn't it?
Yeah, and people are hungry for that.
Yes.
There is a real opportunity here, but it's recognising that within your network. And one of the ideas I had was whether there could be opportunities for leadership programmes within primary care, for example, within workforce hubs, but also maybe opportunities to do what I call shadow board. So, we invite the ARRS roles in to shadow key important strategic meetings, conversations where decisions are made, so that they can experience that, have exposure to it, and they can develop confidence in being a leader within primary care. So that might be something that you could think about.
Yeah, no, absolutely. And I've thought as well around, could you have someone who's a lead role within certainly within those major kind of clinical roles across a network, and then you've almost got a bit of a team of people who can both listen to all the people who lead that role, who are doing those roles, and can also kind of communicate things and help. When there are changes, they can help lead that for the people who are doing that kind of a role.
Yeah, absolutely. And we've got a couple of examples where we've got occupational therapists that have come in and taken on those additional leadership roles. So one OT has taken on leadership for care homes within a network, and another one has taken on leadership for all of the additional roles within the network. So providing that supervision and support, releasing the burden of that from GPs. So yeah, I mean, having a real think about how you can develop your additional roles as leaders within your network and what things they could lead on relevant to their experience and practice is a great way to think about developing our future leaders.
So tell me about your preceptorship idea.
So, yeah, I mean, I talk to a lot of people in ARRS roles that have come into them from other sectors. So, you know, I think, you know, it might not even be a health sector that they've come from, but a lot of people from secondary care are coming into primary care roles. And it is a different place to work. There's different cultures, different expectations, different infrastructures, and how things work is different. So having an opportunity to have what I call like an enhanced induction, where you spend time understanding how primary care works and functions, and also connecting with other new people coming into these roles and building some communities of practice is a good way to be thinking about retention, because often those first few tender months of being in a new job are the time when you make the decision about whether you're going to stay put or whether you're going to start looking for another role. So I think, you know, getting that right, getting your induction right, but also providing this enhanced preceptorship in primary care could be really helpful.
And practically, who could lead that?
Well, that could be, it could be ARRS roles themselves. You know, we've got some very experienced people in these ARRS roles, working with, for example, primary care workforce hubs, and GPs. I mean, this would be, I think, a collaborative effort. So it would be great to get a whole range of different disciplines and professionals in there, helping the new primary care workforce come in. And not to assume, because, for example, you've been a dietitian for 20 years, you know anything about how primary care works. And, you know, providing that level of support in those early months could really help with retention in the long run.
And you talked a bit about the students, about the future workforce.
Yeah, I'm really passionate about this. I've just done a programme where we've brought 18 primary care occupational therapy students into primary care, and you know, we've had them working in care homes. There's a team of us that are doing that, but I do feel like through talking to networks, thinking about bringing in students to primary care practice is really key to these ARRS roles, because they're your future workforce, and exposing them now to how primary care is can be a real way to, you know, to think about primary care as a destination when you qualify, that if you've had exposure to it, you think, I might go into primary care. Hopefully you'll have had a really good experience on placement, and that might be something you think about in the future. So, I mean, the other thing is students can very often help with pieces of work, with projects. So, you know, it's a way to get some extra capacity in, as well as provide somebody with a fantastic learning experience.
And you talked a bit about how often the ARRS roles are kind of working a bit differently to GPs, and the kind of work they're doing is different, and maybe it gets noticed differently. So do you want to explain a bit about that?
Yeah, I mean, some of the ARRS roles are designed to work on, you know, the most difficult problems, population health problems, but also maybe upstream interventions, so that prevention area of work where we are, you know, trying to prevent people reaching a crisis point. But I do think that, you know, the ARRS scheme didn't come with a great deal around outcome measurement and how you understand the impact of these roles. And it is important to understand that impact and what the outcomes are, because how do you know they're effective if you don't do that? How do you know they're making a difference to your most difficult problems? And having opportunities where you can reflect on where you've made a difference for that person as well is really important. I want to know I'm doing a good job. So thinking about outcome measurement and impact data, impact stories or case studies is a real good way to understand, have we got the right roles, working on the right problems, with delivering on the right outcomes for us. And it might be that that's a process outcome, a patient reported outcome. It could be a case study. It could be clinical data. It could be clinical outcome measures. There's a whole range of ways that you can look at collecting impact data. But I know as a network, I'd want to know, is the ARRS role delivering for me on the things that I think it is delivering on? And do we need more of that or less of that? So, when you're thinking about workforce planning annually, if you have that impact data, you can use that to make decisions strategically about, well, we want more health coaches because, this is a real problem, or a lot of people are presenting with this particular issue, so we need to go for more of them, less of them. It helps you think about organising your workforce in an intelligent way if you've got that outcome and impact data.
Yeah. What about sharing between networks, learning?
Yeah, so one of the surprises for me was I didn't anticipate being the messenger of good news. So when I went to talk to networks, we got into conversations about things that were happening, and I was able to say, oh, in this network they've got a dietitian or a paramedic, and this is how they're utilising them and having some really good impact. And then they would say, oh, well, maybe we should think about a paramedic because we've got similar problems. So being the conduit of good news and the messenger in terms of impact, it was a surprising thing to do, but it sort of told me that there needs to be mechanisms in place for that sharing across the system. So where you've tried out a particular role and you've had some really good results, tell your neighbour about it, tell the system about it. We can learn from each other about what's working and what's not working. But is there an opportunity to create a space for that specific to the ARRS role, so that as a place or a system we can start to understand the benefits?
I wonder whether or not that's partly about being face to face as well, because in an online meeting it's very purpose, the strong purpose for that particular hour, but actually it's the bit around the edges where you might have those kind of discussions. And
obviously the pandemic and how we're working and all of the pressures of maybe impact, influenced that not happening, but some kind of learning event or maybe a mini conference or something focused on the additional roles, where you can bring the whole place or system together to understand how these roles are working in other areas. How you've utilised a dietitian, for example, in the management of your population of people living with diabetes, or how an OT is making a difference for your housebound, frail older people. If we could learn from the good stuff that's going on in the system and then use that to workforce plan for ourselves, I think that would be a great thing to do.
Great. So how would you summarise what are the key things that you think people should do differently?
I think one of the biggest assets is your workforce. So if you could spend some time looking at working with your ARRS roles to understand what what would make their working lives really enjoyable. You know, what the human factor side of it. So that's creating that sense of belonging, that sense of connection, providing sufficient support, development and supervision, and maybe how you could do that as a team.
Yeah.
I think that's one of the biggest benefits that you could bring.
Great. Well, thanks for all the time that you spent doing this and coming and sharing that today. So thanks for listening. The Nat's report will be in the description as a PDF. So take some time to digest that and share that. Thank you for listening. I hope it's been helpful.
Thank you.